Refeeding syndrome. Refeeding syndrome is a state of fluid and electrolyte imbalances that can lead to organ dysfunction upon the reintroduction of feeds after a prolonged state of malnutrition. This problem was first identified during war times, especially with Japanese prisoners during World War II. Refeeding syndrome encompasses the clinical complications that occur as a result of fluid and electrolyte shifts during nutrition repletion of malnourished patients. During starvation, intracellular electrolytes become depleted from fat and the protein catabolism. Upon refeeding, there is increased insulin secretion, which stimulates intracellular glucose and electrolyte uptake, leading to hypophosphatemia, hypomagnesemia, and hypokalemia, and also thiamine, B12, and the folate deficiency, and also sodium and the fluid deterioration. Refeeding syndrome can be life-threatening, leading to complications such as cardiac failure, arrhythmia, delirium, and seizure. Regarding assessment, the most important point is to recognize patients who are potentially at risk. Patients at risk include marasmic patient, kwashiorkor patient, 10% weight loss or less than 80 ideal body weight, 5 days on IV fluid only or poor intake for greater than 7 days, chronic disease causing undernutrition, anorexia nervosa, and hypoalbuminemia. Always we should have to ask intake history, weight loss, calculation of estimated energy, and the protein requirement. And also, baseline blood laboratory should be done, electrolyte panel, complete metabolic panel, liver function test, triglycerides, as well as nutritional assessment rates such as zinc, B12, folate, and iron study should be done. Medical assessment, especially cardiovascular stability and the neurologic assessment should be done. Correct any electrolyte abnormality before parenteral nutrition commencement. Aim for mid-normal range during treating this electrolyte abnormality before nutritional treatment. Prescribe supplements prior to feeding. When we see clinical signs and the symptoms of refeeding syndrome, the spectrum of presentation ranges from simple nausea, vomiting, and lethargy to respiratory insufficiency, cardiac failure, hypotension, arrhythmia, coma, and death. When we came to the treatment after it's diagnosed, if a patient has prolonged state of fasting, rehydration is necessary with IV fluids. The type of refeeding, whether it is parenteral or enteral, is dependent upon the state of malnutrition. Reintroduction of enteral or parenteral feeds must be done slowly. The main goal is to provide slow calorie repletion, especially during the first week of refeeding. Initial feeding may begin with 20 kilocalories per kg of body weight per day. During the initial phase, daily monitoring of complete metabolic panel, magnesium, phosphorus level daily is necessary to monitor electrolyte shifts. Electrolyte replacement is necessary for significant abnormalities to prevent organ dysfunction. Fluid balance must be closely monitored by meticulously measuring the patient's total intake and output. Multivitamins should be given and additional thiamine should be provided on its own. Counseling is necessary for those with eating disorders, as these patients can have recurrence of their malnutrition, especially with anorexia nervosa. The highest risk of refeeding occurs in the initial stage during the first 4 or 5 days of refeeding, and this is where the most of complication from electrolyte imbalance can occur. The benefit of treatment is to provide nutrition and obtain a safe weight gain in a monitored setting. This is all about refeeding syndrome. Thanks for watching.